Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo, brought to you by Weevil, Texas. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat will not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon at the navigation bar at the bottom of your window. To all the Vivo Texas providers, please make sure you identify yourselves during this session. Or if you're joining via phone, please email your phone number and name to bwelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking, and we do encourage you to speak. Your mute button is on the bottom left of your Zoom controls if you've joined by computer. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow others an opportunity to speak up. You can also use the chat feature to share your questions and comments. Please note that no protected health information is allowed in either the chat or the discussions, and that includes names, emails, addresses, or any information that can easily identify an individual. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the South Texas Echo team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on substance use navigator services in the inpatient setting and will be presented by Dr. Jananie Ramesh. Following that, we will discuss a case presented by Dr. Jillian Rippin. We will start with some introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we will begin with some introductions. Dr. Ramesh.
Hey everyone, I'm Jan Ramesh. I'm a hospitalist at Dell Medical Center. Happy to be here today.
Thank you so much. Dr. Walker.
Hi, I'm Blair Walker. I'm a psychiatrist with Dell Medical School in the hospital here. Happy to be here too.
Thank you so much. Alana?
Good afternoon, everyone. My name is Alana Bolton. I am the director of Shout Texas. Thank you so much for joining us this afternoon.
Thank you. Dr. Rippin.
Hi, everyone. I'm Jillian Rippon, one of the hospitalists at UT Dell Med.
Thank you so much for joining us today. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm the CSTAF Program Coordinator. Thank you for joining us today.
Thank you. And with that, we will move on to our didactics. Dr. Ramesh, you can take it away whenever you're ready.
Sure. Let me share my screen here. Can y'all see my screen? Okay, perfect. Well, thank you for joining us today. I'm going to be presenting just a really short didactic on substance use navigation in the inpatient setting, and the usefulness of having someone with substance use navigation training in clinical settings in general. I have no disclosures. Here are my learning objectives for the session. First, I'll just ask a question to you all. What does substance use navigation mean to you? Or what do you think a substance use navigator does? What are their primary job functions? What are their main advantages? You can just write in the chat or just say out loud.
Help with resources.
Help with resources. Okay, good.
Chat says referrals.
Referrals. Great. What else?
Ease the process.
Yeah, Awesome. Yeah, these are-
Liaison. I'm reading out of the chat.
oh.
Support.
Mhm. Yeah, they do all of these things and many more. They build connections with the community. They can provide education to patients as well as their colleagues. They can make referrals to things like sober living, rehab, things like that. They can perform screening assessments. They can be advocates for their patients. They can provide counseling, motivational interviewing, behavioral interventions, referrals, it's mentioned, linkages to outpatient treatment and facilitations to outpatient treatment. They can also utilize other colleagues such as peer coaches to help with patients' goals. So on the inpatient side, substance use navigators can wear many different hats. They can screen and interview patients to identify those at risk for having substance use issues. Importantly, they create a judgment-free environment in which a patient who may not always feel comfortable discussing substance use issues with healthcare providers can actually express what they're feeling to them. In this way, navigators can act as the patient's advocate to the healthcare team and provide insights on what treatment plans may work best for this particular patient. They can also provide counseling and education regarding medication-assisted treatment, consequences of substance use, and the pros and cons of various treatment pathways for addiction as well. Another critical role that they play is connecting patients to the community, which you all referenced, connecting patients to the community of addiction treatment, including rehab, sober living, community recovery groups, AA and 12-step programs, and mental health services. Mostly they provide evidence-based care that is non-stigmatizing, informed by harm reduction, and aligned with the patient's goals. So though the functions on the previous slide that I talked about are mostly carried out in an inpatient setting, a really important role of a substance use navigator is the connections that they build with the community. So by staying up to date in the local landscape of addiction care, they can advise patients on which resources and groups to seek based on the patient's own goals. So for example, if the patient does not feel like they can stop using at that moment, but they may have other important goals for themselves, such as wanting to be at lower risk of overdose or poisoning, or wanting to establish with someone for addressing mental health issues, or wanting to have a safe place to go when they're intoxicated. Substance use navigators can help with all of these things, even if a patient is not quite ready to enter recovery. They can also work in settings that are not strictly inpatient, such as emergency rooms, outpatient facilities such as clinics, and in the transitions of care space, where the patient encounters are shorter and more focused. In these particular settings, their expertise can be really helpful for rapid initiation of treatment with medications, or even just planting a seed for further treatment engagement in the future. So in a standard emergency room, if a patient presents with intoxication or withdrawal, the focus of the encounter would normally be to just stabilize the patient and discharge them with follow-up. But the addition of a substance use navigator can help very quickly engage the patient in medication options, set up an appointment with an addiction medicine specialist, and provide harm reduction counseling before discharge. So the California Bridge piloted a program like this a few years ago, and this model has been very effective and has spread far and wide to other institutions as well. SUNs can also work in the outpatient facilities like clinics to provide ongoing counseling and motivational interviewing to patients. So in this type of setting, you really have the more bandwidth to develop that trusting long-term relationship with the patient, to keep them engaged with care and working towards positive goals at periodic intervals. Depending on the level of training and experience that a substance use navigator has, whether they have nursing training, licensed chemical dependency certification, or social work training or case manager training, they can help patients with a large range of things outside of substance use as well, such as housing, food, disability, transportation, and insurance, based on their level of comfort and what the patient needs. So just a lot of various uses and utilities in this position. And in any setting, navigators can really contribute to the education efforts at an institution by participating in research and scholarship. which reduces the stigma around substance use by having these conversations with patients and communicating these findings to other healthcare providers. This really helps institutions that may not have a fully fledged addiction department or a psychiatry department. SUNs are a really good bridge here at these institutions. Navigators can also introduce and standardize the use of certain evidence-based screening and assessment tools for substance use, which can be hardwired into an institution's processes and used by other providers as well for help with diagnosis and treatment decisions. Examples of things like this are audit scores and certain substance withdrawal scales as well. Outside the hospital, substance use navigators can stay in touch with the patient after they're discharged to help them in that especially really vulnerable period between discharge and outpatient follow-up, when a patient is at highest risk of returning to use by returning to their former environment and being surrounded by different triggers and other factors. Even just a general check-in with the patient at this time via phone can be helpful, but the navigators can also provide appointment reminders, encouragement, and help with things like, filling their medications and next steps with establishing their care. So in that transitions of care period, the substance use navigation services are really useful too. So utilizing their connections with the community, navigators can act as a liaison to other facilities as well when patients go to places like skilled nursing, rehab, long-term care, to give handoff to other providers and have that wraparound communication. So what are the unique advantages of having a substance use navigator rather than a traditional healthcare provider around? As I mentioned before, the California Bridge piloted a program with substance use navigators in the emergency department and looked at several patient outcomes. It turns out that having substance use navigators improves follow-up rates and increases outpatient treatment engagement, especially for patients with opioid use disorder who have a lot of medications available to them to help them. If the substance use navigator is present in the emergency department, you can sometimes prevent an admission if the patient is expeditiously started on medication-assisted treatment or has a quick follow-up arranged with an addiction clinic. So some studies have shown reduced ED visits and readmissions for patients who utilized a substance use navigator. These patients, unsurprisingly, also had higher rates of medication initiation. Some patients are more likely to trust someone like a substance use navigator rather than a physician, as I mentioned before, and therefore begin to build that therapeutic relationship. This can carry over to the patient's relationships with other providers where they feel that they're in a safe place and they're not being judged, and can also positively affect the way other providers treat further patients with substance use issues, thus reducing institutional stigma. Given the enormous amount of vulnerability that patients who present to the ED face, utilizing navigators at this stage to help with other social determinants of health is in our best interest as well, since these social drivers drive frequent ED visits and utilization. This is just a shameless plug for our institution at Dell Med. This slide shows the model that we use for our substance use navigators, particularly for alcohol use, although they help with screening for opioid and other drug use disorders as well. So we have a screening tool called the audit that the nursing completes on admission. So any positive screening patients on the audit indicate a high likelihood of unhealthy alcohol use. They get flagged and seen by our substance use navigators. So our navigators then evaluate the patient with a full screening audit, perform a behavioral intervention with the patient to assess their readiness to change their alcohol use patterns, and then ask them for any other help that they may need at the moment. In an inpatient setting, this is a really useful window of opportunity for an intervention because the patient, more often than not, has been hospitalized for reasons related to their substance use or are already suffering chronic health effects from it. The navigator then counsels the patient on their options, including available medications, and if the patient is interested and eligible, the navigator will recommend to the patient's doctor to start an anti-cessation medication like naltrexone prior to discharge. The navigator will then provide additional resources and referrals based on the patient's needs, including setting up follow-up or an addiction specialist referral or primary care referral. After discharge, the navigator will stay in touch with the patient as able, calling them for a check-in about a month out, and then following up with them to see if the patient's alcohol use has decreased. So we've had this program, many of you know, for about 2 years now. And this data is just a quick look at what we've been able to accomplish in 2 years. We've had over 13,000 patients screened with the audit PC, and about 750 of them, which is just about 6%, were positive for risky alcohol use. 530 of them were seen by our substance use navigators and completed a behavioral intervention. And nearly half of them were eligible and interested in naltrexone for alcohol use disorder and started on the medication before discharge. So we were able to discharge 230 patients with a scheduled primary care appointment or a specialized referral, and we reached more than 100 of them for a follow-up call a month after discharge. And more than 70% of them were doing really, really well and had been able to decrease their drinking. Some of them had stopped drinking entirely. So we've had good results with this program, and it's applicable to other substance use disorders as well. And we're so very grateful to our navigators for all the help that they've provided for our patients the last couple of years. In our program and in other programs, there are tremendous opportunities for navigators to further expand their role and provide continued excellent care to patients with substance use disorders. Just the privilege of learning from people with lived experience provides a wealth of knowledge that can be used to help others. These days, programs are also trying to develop culturally tailored interventions for patients from different backgrounds, where the role of drugs and alcohol, as well as seeking help, may look very different. Developing and distributing print materials such as resource lists to help patients, as well as open source material that other providers can use, is one of our priorities. California Bridge, for example, has a wealth of information on substance use navigation and different tools you can use to build out your own programs. The outcomes of patients who have received substance use navigation can be helpful not only for research purposes, but many patients really do well and are very grateful for your help. And so spreading these kinds of success stories at an institutional level can be really galvanizing and helpful for other team members. Substance use navigators can continue to hone their skill set by obtaining additional certification and licensing, and by attending conferences and participating in research. So to connect with people in their area of interest and learn about other best practices in the area can continue helping patients at the local level and nationwide as well. That's kind of all I have for today. I decided to keep it short and sweet. Our case presenter has a wonderful case to present today and some slides to present on behavioral emergency response teams as well. Jillian, I'll leave it up to you as to when you want to present the slides, but thank you guys for listening. If you guys have any questions, comments, would love to hear it.
Thank you so much, Dr. Ramesh, for this wonderful presentation. I'm going to open up the floor for some questions from the audience here today. There's a question in the chat, how to become a substance use navigator? I mean, is there a process for that?
I don't think there's a particular process. People who are substance use navigators have all kinds of different training. You don't have to have a particular, degree or anything. You can have social work training, case manager training, licensed chemical dependency counselor training, and they are useful in a variety of settings, like not just the hospital, but also in a clinic or an emergency department. So I don't know if I can speak to the exact process, but you don't have to have a very particular training for it, because there's a lot of different people who can do it.
I might jump in really quickly and just add to that, Jan, that there are a handful of organizations nationally that do formalized training for substance use navigation. It's not a certification like a community health worker or a social worker, but California Bridge does one. And I think there's a couple other organizations nationally that do either in-person or online training programs to bolster skills and understand the role of a substance use navigator. And we can share those resources after the session.
Thank you. So I had a question. How is a substance use navigator different from a case manager? And seems like a lot of overlap in their roles.
Yeah, there can be. I think case managers especially help with some of those social determinants of health that a patient may have, things like appointments and transportation and those kinds of resources. Whereas substance use navigation can do those things, but also specifically provide the counseling and education around substance use and the resources specifically connected with substance use as well. So they tend to have a little bit more better understanding of the addiction landscape in a place. So they'll know about the rehabs that are available, the sober living centers that are available, the OBOT clinics that are available, and have build those connections there to help patients in that regard.
Thank you. Any other questions or perhaps an experience using such a program in your setting or? All right. We will please keep the questions coming if you have any more in the chat, but we will move on to the next part of our session. Karen, could you please bring up the announcements? And thank you so much, Dr. Ramesh, for the wonderful presentation once again. Thank you. To claim your CME credits for this session, you must have a registered account. If you haven't registered, please text your email address to 844-502-1338. Please text attend 1009-7852 to the same number to record your attendance. You must text by midnight tonight. Next slide, please. We have some really exciting news. Support Hospital Opioid Use Disorder Treatment Shout Echo and the TexRx Echo are joining forces into one new program called the TexRx Medications for Substance Use Disorders Echo. This newly integrated TexRx Echo program will launch on October 24th, 2024 at 12 noon Central and will be available on the new iEcho platform. Moving forward, we'll be offering 2 sessions each month on the 2nd and the 4th Thursday of each month. This echo is designed for prescribers of medications used to treat substance use disorders, including physicians, physician associates, nurse practitioners, and advanced practice registered nurses, as well as allied care health team members who care for people with SUDs. We hope to see you on Thursday, October 24th at our inaugural session. I will now pass it on to our coordinator, Jasmine Vidal, who will tell you a little bit more about the new iEcho platform. Jasmine?
Thank you, Shreya. We're very excited to transition into the new iEcho platform. On the new Echo platform, you can easily join Echo sessions, access session programs, and review content for each session, for each program, all in one place. I'm going to go ahead and share my screen so we can explore the iEcho platform and how it would look for you as a participant. So the first step would be to create an iEcho account. You can create an iEcho account by visiting iecho.org. Once you have created an account, this is how your homepage will look like. You will have on the left-hand side, Echo Stories, Echo Updates. On the middle of your page, you'll have a search bar where you can search for programs using program names, keywords. And right below, you'll have the programs that you're currently enrolled in. On the right-hand side, you'll have your profile completion, announcements, and your journey, how many programs you're enrolled in, sessions you've attended, and certificates that you've received. So once you have enrolled in our program, you'll be able to access it. It'll be under your My Program section. And our program will be TexRx Medication for Substance Use Disorder Echo by University of Texas Health Science Center, San Antonio. And you will see a notification, an orange notification that says, to participate in this program, we need some additional information from you. So this will be the registration form. You can register for the program by clicking on the continue button, and it'll take you to our registration form. You will only need to register for this program one time. So to access our program, you will click the name of the program, TexRx Medication for Substance Use Disorder Echo. And it will take you to our program page. Here you'll have program overview, description of our program, who this echo is for, learning objectives, certification credits, and our contact information. For participants to be able to access our sessions, you will click on the view details, and you will see 3 tabs at top. It will say schedule. On the schedules where you'll find the upcoming sessions and session information, any content that's uploaded for that session, subject matter experts, case presenters. In the middle tab, you'll have the content tab. This is where you'll find content that has been uploaded for our program. This is where we'll be uploading didactic presentations, additional reading material. It will be uploaded and available for participants on the content app, on the content tab. And then the third tab is the discussion tab. So this is for announcements in case we have any information we want to share with our participants about our program. This is where we will upload any announcements that we may have. And this is the Echo platform, very user-friendly. You can log in and see upcoming sessions, all the content, any announcements we might have, all on the iEcho platform. We look forward for this transition, and we hope to see you in October 24th for our first session. If you have any additional questions, please contact us at cstat@utesca.edu. Thank you.
Thank you so much, Jasmine. This is really exciting, the transition, and we're super excited to host this on our new iEcho platform. To get started, you will have to create an account on iEcho, and the BVEL Texas team will be sending out more information with regard to that. With that, we will move on to our case presenter. Jillian, you can take it away whenever you're ready.
Wonderful. Let me go ahead and share my screen here. All right. So before I get started on the case, I wanted to share a few slides introducing a group called BERT, or Behavioral Emergency Response Team, because like Dr. Ramesh had just explained about substance use navigators, these are additionally people who I think could help individuals with substance use disorders, because in the inpatient setting, we see that a lot of these individuals also experience behavioral emergencies, and I'll talk more about this. And so I just want to understand exactly what a behavioral emergency response team is and how they function in the inpatient setting. And I'll try to move through these slides quickly so that we can get into the case. But some questions that while I'm going through these slides and then as we go into the case, I think you all should consider are what roles, if any, do you see for BERT providers in the care of individuals experiencing substance use disorders? And would adding substance use navigators to an inpatient BERT team provide improved care to our community and specifically individuals with substance use disorders? So what exactly is a behavioral emergency response team? It's actually similar to a medical rapid response team that you see in an inpatient setting. It's an interdisciplinary team. They come from backgrounds of different training, which could be actually a substance use navigator, or at least have them be part of the team if they're not the primary BERT clinician. Sometimes the primary BERT clinician may be a psychiatrist or a mid-level practitioner, a floor nurse, but these BERT clinicians are often employed within the mental health setting. Sometimes they're cross-trained, like general medical providers such as myself. We've also seen in some hospital settings that social workers and pastoral care workers and patient advocates might join BERT teams, which is where I started to think about could substance use navigators also be included. The core training is rooted in trauma-informed care, and these individuals specialize in de-escalation. So more about the BERT team. It's flexible and collaborative. It's designed to be implemented in really any hospital, regardless of the geographic setting, psychiatric staffing, and psychiatric financial resources. And its emphasis is to identify early warning signs of behavioral distress, because that is consistent with behavioral urgency and needing intervention. Security staff are available, but frequently not involved when there is a behavioral emergency response team, and it seems to have better outcomes for patients and staff. And BERT is ideally activated before a patient ever demonstrates an outward act of internal distress, again, making security intervention less necessary. So how to implement BERT? These hospitals who have implemented BERT use a proactive screening tool to see who is at risk for disruptive behaviors. And then if those individuals are flagged as having a high risk, then the BERT team is notified and they're able to meet with the patient in advance. Very similar to identifying patients with substance use disorder and connecting them with a substance use navigator. And then other hospitals have taught staff to identify certain behaviors and then notify BERT through an activation algorithm. And in these hospitals, staff members are all educated on what the BERT team is and given educational cue cards on when to consult the BERT team. And this is just a quick example of that, but there is an algorithm that staff will be trained on because maybe not all behavioral outbursts are equivalent to activation of a BERT team. BERTs use calming techniques, environmental changes, and other forms of de-escalation or medication before turning to patient physical restraint, always the last resource. In addition to BERTs changing the patient-directed response, they also emphasize educating the patient's healthcare team to help staff recognize potentially disruptive behavior early. The studies have shown that this helps patients remain in the hospital longer and long-term can decrease their risk for readmission, mostly due to patients who are not de-escalated and cared for in productive means. They end up leaving against medical advice earlier in their hospitalization. So a little bit more about implementing BERT. When the patient-clinician relationships become tense, the BERT providers are there to intermediate and can be a really great resource. They reprioritize the clinical investigation and treatment as indicated, but leave that relationship intact. And then primary teams who witness BERTs, de-escalate and interact with patients also become more skilled themselves in responding to behavioral crises. Again, as we see our substance use navigators in our hospital, I think myself and the residents have really seen the resources and how to engage patients needing that type of help. So a little bit more about what they're proven to be effective in: reducing workplace assaults directed at staff, reducing rate at which behavioral disruptive patients are physically or pharmacologically restrained, are associated with increased staff satisfaction and morale, encouraging and increasing interdisciplinary collaboration, which really helps patients receive comprehensive care tailored to their needs, and promoting a healing environment, which is shifted from security-driven risk management. And I think a lot of the patients who can experience behavioral outbursts are unfortunately our patients with psychiatric disorders as well as substance use disorders. So it's something that is really trying to improve their safety and them receiving the best care possible. The reason that I just quickly wanted to introduce why I came upon this is because here at Dell we are expanding our hospital. We're getting bigger, and we're the only level 1 trauma center serving the 11-county region of Central Texas, and we are considered the safety net hospital for Travis County. And about 1/3 of our patient population carries a comorbid behavioral health diagnosis, which is 1.6 times higher than other academic hospitals. And our population experiencing houselessness is 7.2 times higher than other similar academic hospitals. And in both of these subgroups, there's a lot of these patients who are experiencing substance use disorders as well. And 97% of our nurses, it was a study done in 2022, I believe, have reported exposure to abusive patient behaviors, which is sort of what brought us to talking about implementing a BERT team at our hospital. And this is our code gray, which are security codes sent out through the hospital where security is activated due to a disruptive patient. And this shows sort of the breakdown of how many each day of the week on average, per month and per floor. And total for 2023, we had almost 1,500 code grays. And in the ED was the majority. So patients who are coming in from the street or from home who are experiencing behavioral distress and urgency. And then another one was on our 4th floor, which it typically used to have more of a, it's now a different floor, but the data is a little out of date. And then Thursday and Friday being the most common, which is closer to the weekend, of course. There was some question whether that was due to increased substance use, but hard to say. And then just wanted to quickly highlight that our hospital, Dell is experiencing triple, essentially, the code grays or security and behavioral distress codes compared to other hospitals of larger or similar size in our county. And so breaking down the data, we are having a lot of security codes, behavioral codes, and this is equating to higher utilization of security staff and a greater impact on staff, and really a greater impact on patients as well. And the literature shows that this is increasing nursing burnout, higher staff turnover rates, and decreased job satisfaction. So I have been working together with a team here at Dell to implement a BERT team here, and we're still in the process. But as I get back to our case, I want you all to still consider, would implementing substance use navigators in a BERT team be beneficial for the patients and individuals in our community in the inpatient setting? So to dive into our case, the patient had presented with a severe headache and vision changes, and brief history of what she presented with. She's a 34-year-old woman, history of heart failure with reduced ejection fraction, methamphetamine use disorder, and alcohol use disorder. She came in with the worst headache of her life and decreased vision in her left eye. She said her headache started all of a sudden and was followed by vision changes. While I was interviewing her, she was frequently falling asleep, and I kept having to stimulate her to be woken up to answer the questions. Her past medical history, again, heart failure with reduced ejection fraction due to non-ischemic cardiomyopathy due to methamphetamine use disorder, and then alcohol use disorder. These were her home medications, which she had been prescribed. She did not have them with her. There was question as to whether she had been taking them, and these were the hospital medications that she was prescribed when she was readmitted by the resident on my team. A little bit more about her history. She tells us that her current support system is her friends and her boyfriend. However, there has been witness abuse from her boyfriend actually in the hospital. So it was a question about whether that really is considered part of her support system. She did say also her family, her mother, brother, and sister, but they have a tenuous relationship because they're trying to set boundaries. Part of setting those boundaries is she's actually experiencing houselessness intermittently for the past 5 years, because when she does use substances, her family does not allow her to stay with them. She does have 2 children, but she's only seen them 4 times in the past 7 years, despite having joint custody with her ex-husband. A lot of that, unfortunately, has to do with her substance use, and she doesn't want them to see her in that setting. She walks, she doesn't have a car or really any reliable transportation. She's not employed, and her brother and sister do try to help her out financially at times, but again, trying to set boundaries and don't want to enable her, were her words. For her psychiatric history, she says she has been diagnosed with depression, although she's not currently medicated. She said someone told her in the past that maybe she has schizophrenia because she had a history of visual hallucinations, but she was never formally diagnosed and didn't have any psychiatric hospitalizations. So how this case unfolded in the hospital, her vision changes were actually found to be due to a stroke. And the stroke was thought to be due to a cardioembolic event because she had a very large thrombus in her left ventricle. The cardiologist actually called me on my cell phone and said it was the largest clot she's ever seen in someone's left ventricle. And this is due to just severely decreased heart function and low flow state. And unfortunately, it was mostly due to her methamphetamine use disorder, causing her heart failure and frequent exacerbations.
Dr. Rippin, would you be
Yes.
able to pull up the case if you don't mind?
Oh, is it not showing?
No, it's not showing.
Oh no, so sorry. Let me change. I didn't realize it didn't. Thank you so much for telling me. Okay, is it showing now? Okay. Okay, so sorry about that. So I can try to scroll back up and maybe minimize so you all can see a little bit of what I've talked about. So she was placed on blood thinners to treat the clot in her heart. and cardiology was involved. Unfortunately, that evening, she became very agitated because she was told by the charge nurse on the floor that she was not allowed visitors. This was unfortunately due to a previous hospitalization when one of her visitors stole an associate's belongings, as well as another event in which her boyfriend actually assaulted her in her hospital room. So she had multiple events. This was actually her third admission within the last 1 month. My second time meeting her, I had actually taken care of her at SMCA 2 weeks prior to this. And she had had these multiple events in which staff decided it was no longer safe for her to have visitors. And this was very upsetting to her. A code gray or was called, and security went to bedside, and she was warned regarding a behavior contract. And she actually was placed on a behavior contract, which is where our nurses have the patient sign a piece of paper saying that they will comply with staff, and if they do not, then they will be discharged from the hospital. The next day, she, in the afternoon, was missing from her hospital room, and she was found in the hospital parking garage speaking with an individual who she said was a family member. Security escorted her back to her room, but she became increasingly agitated, was yelling at staff and not wanting them to enter her hospital room with her. And at that time, staff reported this was a breach of her contract and they wanted to discharge her from the hospital. And that was when myself and one of my residents were called to bedside, and we were able to speak with everyone and try to diffuse the situation. And ultimately, nursing staff did allow the patient to stay to receive the treatment that she needed. And once everything was de-escalated, the patient stated that she was trying to go find this person to talk to them about getting additional medication that the hospital would not give her for help with sleep, because she was having visual hallucinations of rats running around her room, and she was not able to sleep the past few days, and it was really upsetting her. She also felt like that was causing some of her behavioral issues. During this process, after she had returned from the parking garage, before the situation was completely diffused, security also had searched her and unfortunately found paraphernalia believed to be methamphetamine in her possession, and it was confiscated. And this was, I think, around 8 p.m. When everything finally diffused. And in the morning, unfortunately, she decided to leave against medical advice. She did have capacity, and we tried to have her stay so that she could get her medications, that we could try to find a place for her to go, follow-up appointments, things like that. But unfortunately, she was adamant about leaving. And so additional comments about this case, like I said before, this was actually her third admission within 1 month and her sixth admission within the last 3 months. Most of these admissions were related to heart failure exacerbations, which were seemingly due to barriers with adhering to her medication regimen, as well as continued methamphetamine use. Interestingly, she has when you open her chart, she has a lot of flags that pop up. One of them is for high risk behavior and violence issues due to the security issues that have happened in her previous admissions. And she screens high for suicide risk as well. And interestingly, up until this hospitalization, she had never had a conversation with a substance use navigator. But when I talked with her about it prior to her discharge, she did say she was interested in cessation of methamphetamine use and alcohol use and wanted help and wanted to be reunited with her children. So one of those things where it was potentially a missed opportunity. And potentially, if a substance use navigator was a part of a behavioral emergency response team, she could have really benefited from the integration of care. And this is scrolling down a little bit more about.
Jillian?
Oh, yeah. Mhm.
Yeah, if you could summarize maybe in a little bit so that we know, we can open up the floor for some questions from our audience as we are running
Yeah.
close to time. Yeah.
Yeah. So this is a 34-year-old woman with a history of heart failure, methamphetamine, and alcohol use disorder who came in with a stroke due to a left ventricular thrombus. And her hospital course was complicated by behavioral issues, and she unfortunately left against medical advice due to these behavioral issues, as well as seemingly wanting to return to methamphetamine use. And at this time, she was not discharged with the medications or follow-up appointments that she needed. She was essentially lost to care when she left against medical advice. And so the questions I had wanted us to consider were up here, but that's essentially the case.
Thank you so much, and thank you for bringing this case to us. I'd like to open up the floor for any questions from our learning community here.
Yes, I have a question, if I may.
Of course.
What is the state? I'm just curious, the state of this patient right now. It seems like it's really serious. The heart, the stroke that she had and all that. She's right now taking care of her health issues. Is she doing better? Is she able to manage at the same time the situation with substances?
So shortly after this event, she was rehospitalized with a recurrent stroke about 6 days later. And she didn't have further deficits, luckily, but she was readmitted to the hospital. And at that time, one of our substance use navigators, Rachel Holloman, was able to meet with her and is in the process of trying to, the patient actually is still in the hospital, and Rachel's working with her to try to find a better outpatient situation for her so that she can get the help she needs.
Thank you. Any other questions about the use of BERT, or if anybody else has similar experiences and would like to share?
Thanks, Jillian, for bringing this case forward. I think your question about whether a substance use navigator would be helpful on a BERT team or a similar setting is a really good one, because when these like code grays and behavioral responses get activated, it's a super chaotic situation. It's really tough for everybody involved, especially when substance use is suspected. And I think oftentimes like the other providers, the security teams, their incentives don't necessarily align with the patients. And so, you know, it's a very like punitive situation. Like if paraphernalia is found, the patient is automatically discharged. And that's not even taking into account like the patient's autonomy has been like compromised at this time. They've been, you know, searched, and they're feeling like very guilty, humiliated, and they're already in a place where they're not going to want to cooperate with you when you're accusing them of something. And so I think a lot of us have seen situations where patients are like discharged from the hospital, or just that therapeutic relationship is totally destroyed after an event like this. And it's just really hard to rebuild that trust back and get the patient the help they need. So I think like these de-escalation tactics, whether they come from like a BERT team or a substance use navigator, can be really helpful for the patient, and also just trying to get everyone involved and say like, hey, we don't have to escalate this situation any further. Let's try to figure out how we can help the patient with their substance use and not automatically jump to punishing them. So I think it was great that the ND and everyone got involved in this patient's case and prevented her from being discharged that first time she was found in the parking lot. That must have taken like a lot of effort and a lot of coordination. So I'm glad that now it seems like she's getting the help she needs.
Thank you. I see a question here from Danielle. How many people are there on a bird team?
It varies from hospital to hospital. Typically, it's 5 providers. For our hospital, we'll actually only be implementing 1 BERT clinician who will likely be a nurse. But it also compromises a liaison from security, usually hospital medicine, nursing, like charge nurse of some sort, or nursing administration, and then a safety council. So depends on your hospital size and need, but usually 5 people are involved in 1 primary BERT clinician in our case.
Thank you. We are running close to time, so I thank you again, Dr. Rippin, for bringing this wonderful case to us and speaking to us about the BERT teams and their utility in the hospital setting. And thank you again, Dr. Ramesh, for that wonderful presentation. Dr. Ramesh, if you could please provide a quick summary of today's session, it'd be really helpful.
Yeah, thanks again, Jillian, for bringing this case forward. The case was about a young woman with substance use disorder and multiple behavioral and psychiatric issues, and the challenges that she faced with accessing the care that she deserved. And we talked about how behavioral emergency response teams can be helpful in de-escalating behavioral emergencies in the hospital to help patients stay in the hospital longer, reduce AMA discharges, and build on a therapeutic relationship with the patient.
Thank you so much. And with that, I'll request Alana to provide some closing comments today.
Yeah, thanks, Shreya. I just want to take a moment to recognize not just our hub team members and our case presenter today, but specifically all of the attendees that have attended this session and all of our Shout Texas Echo sessions over the last, I think it's been 4 years that we've been doing this series. And this is our last standalone session, as Jasmine shared with us during the announcements. So we're looking forward to our combination with the TXRX Echo, and we hope to see all of you and all of your colleagues on our new combined Echo series in the future. So thank you again, everybody, for your support of our program, and we'll hopefully see you next month.
Thank you so much, Alana. And thank you all again for joining today's Echo session. As a reminder to earn C credits, please text the activity code 1009782 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey will be open for 1 week. We look forward to seeing you at our next session on Thursday, October 24th on the new iEcho platform. We are excited with the new launch, and we hope you are as well, and we'll see you there. Thank you again for joining us, and have a wonderful rest of your day. Bye-bye.